Okay, so again, thank you so much for doing this. Um, I offered you to, I mean, asked you to have an interview with me regarding the way you practice psychiatry and the way you think DSM influences everything. Because in France, it's special. We have psychoanalysis on one side,
Mhm.
and then if you want to practice evidence-based psychiatry, you have the DSM, and it's something that is used to set a rule and a standard between all psychiatry and evidence-based. I think that's an issue. I'd like you to hear your thoughts on that.
Okay, I'd be happy to. Um, so I'll speak maybe for like 5 minutes or so about DSM,
Yeah, it's fine.
as best as I can summarize it, and then you can ask me to expand on certain parts that I will go maybe less on. So DSM-3, third edition, is the version that is the basis for what we use today. It came out in 1980, and there are two aspects that are important to it. One is what people call reliability, and the other is validity. Reliability means it was a common language, like a dictionary, that we can all at least speak a common language. Most people would agree that it was successful in that. Validity is that it's correct. In other words, that the descriptions given are actually real in the world of biology or in existence. And that's where it's not correct and not real. And in 1980, it was the leaders of DSM-3 did never claimed that it was valid. They only claimed it was reliable. They said, let's create a language, a common language, and then over time we'll study it and change it. And the parts that turn out to be not true will change. And that's what future revisions were supposed to be. It would become, the validity would happen over time. But unfortunately, the dictionary became a Bible. And if you worship the dictionary, then you never change the words. And there are words in the dictionary that can be very well described, like unicorn, but they are not real things. And it's the same thing with the DSM definitions. In fact, in 1980, when the DSM definitions came out, we can prove that they were not valid by the fact that there was no research at the time that showed that they were correct. What happened was there was about 14 diagnoses for which there was research on validity. These were called the Research Diagnostic Criteria, the RDC. And validity meant if you take a bunch of symptoms, you can show that those symptoms are different from other symptoms in terms of two different diagnoses based on independent criteria. It can't be just symptoms because different symptoms don't mean different diagnoses or diseases in medicine, as we know. The same symptoms can occur in different diseases, different symptoms can occur in the same disease. So symptoms alone are not sufficient. In medicine, we have pathology. In psychiatry, we don't have pathology. So what they used was genetics and course of illness as independent validators for validity of a diagnosis. So they would argue, for instance, that bipolar and major depressive disorder, they're different valid diagnoses because they have different genetics and different course of illness. That's how you would say that. Or that schizophrenia is different from bipolar because it has different genetics and different course of illness. So there were 14 diagnoses which they could show this kind of validation in 1978 when the research diagnostic criteria were published. 2 years later, in DSM 3 in 1980, they had 292 diagnoses. So they went from 14 to almost 300. And essentially, they made up the other 270 diagnoses in 2 years, with the committee sitting around and just talking about coming up with a consensus, then the opinion of clinicians. How do people define narcissistic? How do people define borderline? How do people define ADD? They just made it up out of nothing. And then they said, okay, at least we have the definitions, we'll change it over time. But with the fourth edition in 1994 and the fifth edition in 2013, what happened was that the leaders of those DSM committees said, don't make any changes. DSM-3 is so good, we don't want to make changes. We only make small changes if there's lots and lots of reason to do it, like maybe a lot of research data or sometimes just a lot of opinion. But otherwise, we won't change it. And so the DSM-3 definitions, which were made up 95%, 280% just made up with zero evidence, have been left unchanged for almost 40, 50 years now. And people don't realize that they never have been improved and validated. They've just been left the way they were. A good example is personality disorders. They're exactly the same as they were in 1980. In fact, in the fifth revision, researchers got together in the task force and they said, these are not valid. These are mostly proven invalid. We should take 6 out of 8 out. And that was their proposal. But the board of trustees of the American Psychiatric Association vetoed them and left it the way it is. So that's the way decisions are made with DSM. They were unscientific in terms of validity to begin with, and they've remained that way for half a century.
And we've just had a podcast about people saying the DSM made psychiatry non-humanistic, and we were stuck with criteria. Do you think? I think that's honestly not really a good critique to the manual. I think psychoanalysis wasn't really humanistic before the DSM. I think it was something that made the DSM to begin with. I would like to hear your thoughts.
Yes, definitely. So, DSM had 2 successes and a failure. One of the successes was reliability. Failure was validity. But the other success was that it destroyed the psychoanalytic hegemony in the United States. Before 1980, basically all diagnoses were psychoanalytically defined. And so people were getting diagnosed with schizophrenia just because on the psychoanalytic couch, they might hear a voice. So they were diagnosed with schizophrenia if they had panic attacks because depersonalization was defined as psychosis. Manic depression was rarely diagnosed. So the practice of psychiatry in the US before the DSM-3 in 1980 was very psychoanalytic in both good and bad ways. The good way was, obviously, there are some insights that Freud and his followers had that can be useful for many people. Freud himself said that psychoanalysis was useful for normal people, not sick people, and it may reflect something about normal psychology. But it was bad in the sense that people with schizophrenia and manic depression who had real biological diseases were getting misdiagnosed as having problems with their unconscious emotional relationships to their mother or father and put on the couch for years of psychoanalysis, which is not helpful. It's not humanistic to take somebody who has a biological disease, not treat it when there is an effective treatment like lithium for manic depression, and then talk to them for years on end as they continue to suffer. That's not humanistic. It is humanistic to take people who do not have biological diseases and talk to them in psychotherapy and so on. And so the problem with the old psychiatry of psychoanalysis was it totally rejected biology and disease concepts falsely. And the problem with the post-DSM psychiatry is that it's not that it's biological, which is a common mistake. It's not disease oriented, it's not scientific, it's not the medical model. What it is a very postmodernistic, eclectic, vague mishmash of ideas so that anybody can believe anything they want to under the rubric of the so-called biopsychosocial model. So you can take DSM concepts and you can use drugs if you like, you can use psychotherapy if you like, you can use psychoanalysis if you like, you can do anything you want and no one can stop you. And the problem there is that sometimes people get the wrong diagnoses, they get the wrong approaches to whatever their problem is. And so that can be very unhumanistic itself.
Can you expand on what's a disease and what's not a disease in the DSM for you?
Well, DSM, I would say, there's a difference between validity and disease. So validity just means that the syndrome is real. The syndrome could be a non-disease syndrome. It could be a psychological problem, like post-traumatic stress, for instance, which I would consider a legitimate, valid syndrome. But a disease is a abnormality of the body, which results in some kind of either symptoms, not always symptoms, like when you have early cancer, you have no symptoms, but it results in some kind of physical or psychological or other problem in one's functioning, but not necessarily one's functioning in one's health. So, for instance, if you have cancer and you have a small tumor in your ovary, the disease is there. You have no symptoms. You function fine. But if you don't identify the disease and treat it, it will kill you. That's what I mean by disease. I apply the same definition to manic depression and schizophrenia. There's abnormal cells in your brain. They will kill you unless there's a treatment. And for schizophrenia, we don't have one. In manic depression, we do.
And what's the difference between like manic depressive illness and ADHD?
Well, ADHD is not a valid diagnosis. It's not a real thing. Manic depression is.
And when you mean it's not a real thing, is it that the symptoms are, do you mean the symptoms don't exist? Or the symptoms
No, the symptoms exist, but
yeah.
just like if you look at medical history textbooks in 1750 and 1800 and 1850, people defined all kinds of symptoms all kinds of ways. But we don't use those diagnoses anymore. We don't use those terms. That doesn't mean those symptoms didn't exist. It means the doctors at that time made false judgments about the diseases or diagnoses that those symptoms represent. Same thing with ADD. There are symptoms. The symptoms are attentional impairment and executive dysfunction. What current contemporary mainstream psychiatry says is this is a diagnosis. They call it ADD, and that's a real thing. And what I'm saying is you can call it what you want, but if it's real, you need to show me the validation research in genetics and course of illness, the validators. And when you look at that for adult ADD in particular, but also for child ADD, as I've published, we've documented this, the evidence is not there that that validates the diagnosis. The evidence invalidates the diagnosis. Just to give you an example, if ADD is a legitimate disease, then its genetics should differentiate from other diagnoses and diseases. But the genetics do not differentiate from bipolar illness or from mood illness.
And can you tell
So it's
me?
not a separate condition.
Yeah. Can you tell me one DSM diagnosis, real or not, that exist or not, within which there is no attention deficit or executive functioning deficit, or it's present about in diagnosis?
Well, technically hypomania, although it's not a diagnosis, it's a phase of bipolar illness. But in the hypomanic phase, your attention is improved.
Yeah, okay. Maybe one part. Yeah,
One
okay.
part of it.
Not too late and not
but you're
too
right. I mean, the main diseases are schizophrenia, manic depressive illness. In both cases, you have executive function and cognitive impairment. OCD, probably the same. PTSD, probably the same. Autism, probably the same. So in all of these conditions, you do have cognitive impairment, but it's not the things that people are diagnosing as so-called ADD, like a 7-year-old kid who's can't pay attention in school. You know, that's not schizophrenia, although there is cognitive impairment in schizophrenia.
Okay. Would you agree that these issues apply to mid-level mental illness? I don't know if I'm making it live. If you see a patient that has textbook schizophrenia or textbook bipolar, it's a lot easier, right? You see manic phase, and there isn't much debate about whether or not it's a disease or not. It gets cured, and I think the more we're going forward, the more we're diagnosing mild cases, which may eventually become serious, but mild cases, and there's a whole dimensional issue and everything. And I've seen in my practice, I see a lot of patients coming up for ADHD. That's probably one of now, honestly, one of the main concerns people come with. And what would be the issue of treating ADHD and missing one of the other main diseases, as you said?
Well, the question is, just like, in the 1850 diagnosis of Z turns out to be cardiovascular disease, and now we can treat it with statins. In 1850, they had no idea. Same thing with ADD. ADD, what we're calling ADD, is actually something else, a couple other things. And maybe we can treat those. And since we're not thinking of it that way, we're using amphetamines and not treating it better. Let me give you an example. We did some research where we showed that about 1/2 or so, maybe a little more, of the patients that came to our clinic who had been diagnosed with adult ADD actually had mood temperaments. So mood temperaments we can measure with this TEMPS scale, which is a self-report scale, but also with the clinical history. And just to explain it for people watching, mood temperaments are mild manic or depressive symptoms that are always there as part of your personality. Most people are familiar with dysthymia, which is mild depressive symptoms, cyclothymia, up and down, but they're not familiar with hyperthymia, mild manic symptoms all the time, just because for non-scientific reasons it was never included in DSM-3 or onwards. And even in the DSM, the word cyclothymia and dysthymia is not understood as a temperament. It's viewed as a quote unquote disorder, which is one of those vague, meaningless words in DSM.
Sense.
Yeah, which we can talk about. But the concept of cyclothymia and dysthymia and hyperthymia go back over 100 years. They were described by Kraepelin and others. The terms were used by Ernst Kretschmer and others in Germany in the 1920s. And what they all saw it as was a mild variation of manic depressive illness. So in other words, when someone has manic depression, like you said, sometimes it's obvious they have a severe depression or a severe mania. But in between those mood episodes, when they're not severely depressed or manic, what are they like? Well, there's some research that we showed that half the time they're normal. They're just like you and me, walking around normal. But half the time they have a mood temperament. They're a little up, they're a little down, they're a little up and down. They're either dysthymic, cyclothymic, or hyperthymic. So this mood temperament is actually part of the disease of manic depressive illness. It's just not part of the severe episode. It's the inter-episode phase. Another aspect of the mood temperaments is that they happen in family members of people with the more severe disease. So if you take someone with bipolar illness or severe unipolar depression and you look in their family members, you find very high rates of cyclothymia and hyperthymia and dysthymia in family members who don't have any depression at all, who don't have any manic episodes. So they don't actually come to doctors often. They're not diagnosed or treated with anything. If you're not looking for mood temperaments, they'd be called normal. But in fact, they have mood temperaments. And that seems to happen in some studies in as much as 20% or more of family members. So remember, bipolar happens in 1 or 2% of the population, but mood temperaments may happen in 10% or more of the population. So it's a lot of people. So what's the prevalence rate of so-called ADD? 3%, supposedly, according to the epidemiology studies. Well, the prevalence rate of hyperthymia and cyclothymia is easily 3% of the population. Now, if you're manic all the time, are you going to have a good focus and attention? Are you going to have good executive function? No. But on the other hand, if you're not diagnosing hyperthymia and cyclothymia, you're not diagnosing manic depressive illness this way, you're going to ignore the fact that they're manic. You're going to see the effects, which is the executive function and poor attention, and you diagnose the effects instead of the cause. You diagnose ADD instead of cyclothymia, hyperthymia. And then you treat the effects instead of the cause. Well, how do you treat the effects? You give them amphetamines. Amphetamines improve attention. Okay, good. You might say, what's wrong with that? Well, that's like having a pneumonia and treating the fever with aspirin or acetaminophen or ibuprofen, but not using the antibiotic to treat the cause of the pneumonia. It's much more effective to treat the cause than the symptoms. Sometimes you can control the symptoms that way, but oftentimes they come back. So I've had many cases in my clinical practice where I have patients come to me with so-called adult ADD. They've taken 1 million amphetamines. They've also had some anxiety. They've been on benzodiazepines. Of course, the amphetamines cause anxiety. They've had depressive symptoms. They've been on all the SRIs for that and for the anxiety. So they've been through all the SRIs, all the amphetamines, all the benzodiazepines with ADD as a diagnosis, and maybe MDD and maybe generalized anxiety. And I assess them with their history and with the temps. I see they have cyclothymia or hyperthymia. I give them a low dose of lithium or Depakote, 300, 450 milligrams of lithium, and it all goes away. All the ADD, all the anxiety, all the mood symptoms, it's all gone because you're treating the cause. So that's the approach to adult ADD that I take. And that's, I think, what our mainstream psychiatry is totally missing. It would be as if infectious disease doctors only diagnosed and treated fever disorder instead of the actual infections.
And I remember when I was a student, I went into infectious disease department and they asked not to give Tylenol not to give aspirin ever, so they could track the fever. So basically, that's like putting someone with ADD on amphetamine without looking for a better hierarchical approach. Is that right?
Yeah,
Is that
right. And also the it would be also a little worse because in some people they get worse. It would be as if Tylenol made the bacteria grow faster. So what amphetamines do is they make the manic symptoms worse. So then that causes even more poor attention, even more anxiety, and then the patients end up on even more amphetamines, and it becomes a vicious cycle.
And how do you define manic? Because people come to me and they say, "Yeah, I'm not euphoric. I didn't buy two cars, so I don't have
Yeah.
bipolar." And it was International Bipolar Day, like
Uh-huh.
a month or two, and I'm primed for that because I have bipolar, so I pay close attention. And about everyone on social media, as I said, look, it's periods of hypomania, euphoria, and then depression. If you have these, please consult. Can you expand on what's wrong, what's terribly wrong with this?
Yeah, they're not making the distinction between episodes and symptoms. So there's manic episodes and then there's manic symptoms. Those are two different things. So again, this is very much driven by the DSM hegemony. And they just look up DSM, they look up the definition, and then that's what they talk about. But since DSM is false, mostly, they therefore are spreading false ideas. If you ignore DSM and you go back 100 years, 200 years in psychiatry, and go back to Pinel in 1800 in France. The definition of mania in Pinel's textbook, which remained the definition for 100 years in Kreplin's textbook, was psychomotor excitation. And that goes all the way back, actually, to the ancient Greeks. Hippocrates defined three psychiatric diagnoses: mania, melancholia, and phrenitis. Phrenitis was when you had fever and insanity. Mania is when you had psychomotor excitation and insanity. And melancholia is when you have psychomotor retardation and insanity. So, and that's essentially the way it remained defined into the 19th century, into the 20th century, before 1980 with DSM-3. So manic symptoms basically mean you're psychomotor excited. You're hyperactive in some way. You're overactive. You don't have to be euphoric. You don't have to be irritable. You could be depressed. Your mood is totally irrelevant. Mood is not part of the diagnosis. It's psychomotor excitation. You're psychologically sped up in your thinking, movement, and feeling. You're physically sped up. And depression is psychomotor slowing. It's not being sad. You can be completely normal in your mood and have a full-blown depression, as everybody knows. You can have anhedonia without any mood at all and have a depression. It's not sadness. It's slowing down of your thinking, movement, and feeling. It's psychomotor slowing. And when you have mixed states, you have both. You might have some of the mood with the opposite psychomotor state. So sad mood with psychomotor excitation, happy mood or normal mood with psychomotor slowing. Those are mixed states. And those are very common. So manic symptoms can happen outside of manic episodes and hypomanic episodes. The episodes are the DSM definitions, if you want to use them, when people have multiple symptoms lasting for weeks or months on end, and it has a beginning and an end. It comes and it goes. That's the episode. But as I said, in between the episode, you could have the symptoms every single day of your life. You could be psychomotor excited every day, hyperthymic temperament. You could be psychomotor excited one day and psychomotor slow the next day, back and forth every day of your life. That's cyclothymia. So this would be like saying if you have a pneumonia, you know, we define a pneumonia as having fever, chills, night sweats, lung inflammation, and maybe a couple other symptoms. That's a full-blown pneumonia. But if we say, look, if you only have half the symptoms, that's not a full-blown pneumonia. That's nothing. You know, a little bit of inflammation, that doesn't count. A little bit of fever, that's nothing. So with bipolar illness, people take this all or nothing attitude. If you don't have a full episode, it's nothing. We completely ignore it. They ignore all the symptoms that can happen short of a full episode. And it's not minor. These so-called mild symptoms, which cause these mood temperaments, actually are the things that everyone's getting diagnosed for incorrectly today with generalized anxiety, major depressive disorder, and so-called ADD. And then they get amphetamines, benzodiazepines, and SRIs. These are actually many of the patients that walk around that are completely undiagnosed. Right.
And these are the ones
And
that
these are the ones that
aren't not improving. I don't know if you think that. I mean,
Yeah,
my
I
questions.
think they're not improving much. You know, they might improve some because you can get some symptomatic benefit. You know, the SRIs have symptomatic benefit for anxiety. Obviously, the benzodiazepines do, the amphetamines do for attention. It's just enough benefit to fool everybody. And then the psychiatrists think they're helping, the patients think it's good, and then they stay on it for decades and decades. You know, there's a good number of them that don't get better, and those are the ones that maybe I see who try to look for a different way of thinking about it. But I think we could actually help people a lot more than we are doing if we stopped taking a Tylenol-based approach, a symptom-based approach to psychiatry, and we took a disease-based approach and try to get at more of the underlying causes.
Okay, I'm going to try to, ask questions that people who are not agreeing with you would. If we are to stop using the DSM, what would we use? Because I've talked about it a bit and I've been attacked like I've never been, honestly. It seems surprising. Maybe we'll talk about that. But people think you're talking because you're not embracing the DSM. You're talking about the air doc and high top, if I'm pronouncing it correctly.
Yeah,
That's not what
yeah,
you're talking about, right?
no, I don't agree with those either. The problem with RDoC is it's just a DSM made up by the National Institute of Mental Health. It's people sitting around the table and just making up diagnoses out of nothing again. It doesn't help to say Stalin was wrong, Trotsky is better. You're just making things up.
Yeah.
Science is not scientific data is not achieved by sitting around a committee table and just giving your opinion. You have to do studies and show the data. So that didn't do that. There's more one could say about why RDoC is not correct. It's also biological and not clinical,
Yeah.
so it's not relevant for diagnosis. High top
Exclusively,
has what's
exclusively
that?
biological. It's like
Exclusively,
exclusively
yeah. So
biological.
it's its own ideology, and
Yeah.
it made the mistake of thinking that DSM was based on clinical research, and therefore we should shift to biology. The problem was the DSM wasn't based on research at all, clinical or otherwise, which is what I support. I support clinical research diagnostic criteria. I call it CRDC. It's like the old research diagnostic criteria of the 1970s. I'm not saying anything revolutionary. This was actually mainstream psychiatry in the 1970s before DSM-3, at least among the researchers. I'm just saying we should apply clinical research data for our diagnoses, and that's it, not a group of bureaucrats sitting around a table at the American Psychiatric Association. High top also, I just mentioned, it's not as good because it totally ignores the course of illness. It only looks at current symptoms. So we need to look at the course of illness and genetics, not just the symptoms. And again, that's mainstream accepted view to how to do validity research in psychiatry. It's just not applied. So all I'm saying is, what's the solution to DSM? Science. Apply research. Everything everyone says that we should be doing, but we actually don't bother doing. The problem with our profession is we don't realize that DSM is unscientific. It is not based on research. It is not based on data as its primary or main source of information for criteria. And the leaders admit it. I'm not making this up. The leaders said so when I confronted them. It's in writing. I can give you references. But the other part about it is ask yourself this question. Well, become aware of this issue. Psychiatry is the only specialty in all of medicine that has a DSM. Psychiatry is the only specialty in medicine that goes about diagnosis this way. And if we want to claim that psychiatry should be like medicine, that we should be equal to them, we should have similar rights or whatever, why do we act differently? That's not the case in neurology, dermatology, infectious disease, cardiology, rheumatology, name it. None of them have a professional organization that sits down and says, okay, let's get 100 people around 10 tables. Each one of them is going to define every single possible diagnosis in our profession. We're going to make a list, and then everybody needs to follow that list to the letter for the next 10 years. And we won't change it at all for the next 10 years. And then the next time around, we'll change it 5%, but you have to follow it for another 10 years. There's no profession that does it. So I would turn the question around. Why do we follow DSM when no other physician does it, when scientific medicine does not have this approach to diagnosis?
And were you taught to follow the DSM? Because I mean, when I was a student, I had to learn the symptoms one by one, and it was something to be proud of. We had to wear coat, and that DSM on the on the code something. Did you have to do that too?
Yeah, I graduated my residency in 1994, which is the year that DSM-4 came out. And it was only 14 years after DSM-3. So there was, at that time, a lot of excitement around DSM-3, 3R, DSM-4, and we all accepted it without any doubt. I can speak for myself. I assumed that it was true. I assumed that there was research behind it and that it was true, that it had been valid. And, I had enough faith in my profession and our leaders that I just assumed that's the way they would approach it. And I continued to have that belief for at least 10 years, maybe almost 20 years until DSM-3, DSM-5 in 2013, about 10 years ago. And a few years before that, as the DSM-5 process started, I had been in the field by that point for 15, 20 years. I had published a good deal on bipolar research, on definitions, and so on. I was actually the chairman of a task force for diagnosis for the International Society for Bipolar Disorder Research. So a lot of my friends were involved in the DSM-5 committees, so I got to see what it was like. And at that point, I realized that they were not going to use the research that had been published in the prior 15, 20 years
Okay.
that showed some things that needed to be changed. For instance, it was very clear that there was zero evidence that 4 days was a
Yeah,
valid
2 days.
cutoff for hypomania. Yeah, that could be 2 days, could be 3 days, but it wasn't four. It was clearly not four. And they didn't change it at all because they didn't want to. And there were other examples, the personality disorder example I gave you. Once I got into it and I realized that DSM-5 was not going to change much from DSM-4 and they were going to ignore legitimate scientific research from the prior 20 years, I realized that the whole thing was a sham, an unscientific sham. And I became quite upset about it because, I'd spent 20 years in the profession. I was no longer a young, health, energetic 30-year-old. I was a little more tired 50-year-old. And I thought that was unfair to me, and it's unfair to you. It's unfair to the patients, obviously, but it's also unfair to the doctors and the clinicians and the researchers who go into this field like we all did, believing that things were true and believing that our leaders were leading us based on scientific truths. And we got in and we realized, no, actually they reject scientific research. And then that means that the field doesn't progress. So we all get old and we all practice and we essentially waste our time in a profession that's standing still on purpose. It would be bad enough if it was just not progressing despite people's efforts. They're actually making the effort is in the direction of regression, of keeping the profession from progressing. And that makes me really unhappy. I have to say, mildly unhappy. I would say upset if I was honest, angry. But that's only been in the last 10 years, to be honest with you. Before that, I was a believer like everybody else.
Yeah, okay. I had a child psychiatry professor who told me like 2 days ago, there is nothing arbitrary in classification. If there is something like that, it stops being classification. So he basically said DSM-5 has nothing arbitrary in it. Could you tell
Oh,
us
that's
what you
definitely
think?
not true. I mean, I was in 2000. I'll tell you a little story. In 2000 and DSM-3 came out in DSM-5 came out in 2013. 2011 or so, I was invited to go to a conference in Copenhagen with other leaders of the prior DSM-4, DSM-3 who are still alive, and DSM-5, and some European leaders in diagnosis. It was organized by Kenneth Kendler, who was one of my former mentors, very well-known psychiatrist. He was nice enough to include me. And some of the DSM-3 and 4 leaders were there. And I asked them about the 4-day hypomania definition. I said, where did you get 4 days as your cutoff for hypomania? And one of the leaders of DSM-3, DSM-4 said, well, we had 1 week for mania, so it had to be less than a week. And we thought a day or two was too short. So we went in the middle for 4 days. Arbitrary. That's literally how they defined it. So your professor, your colleague is wrong. And the proof is you can talk to the people who actually created the DSM-3 and 4 and they'll admit it.
And I mean, are you alone thinking that? Or you are
I'm alone talking about it, maybe one of the few that talks about it, at least in the academic psychiatry profession, yes. There was a writer who was a patient who published a book a few years ago about having received something like 14 DSM diagnoses and having had a lot of trouble in her life about it. It was basically a memoir. And when she and her editors tried to find um, medical uh, leaders who they could quote or cite to support them, I was the only person they came to. And I was the only person they found. They couldn't find anybody else who was speaking critically about DSM within the medical psychiatric profession. There are plenty of people outside of psychiatry, and that's something worth noting. See, I disagree with the supporters of DSM, and I disagree with the opponents of DSM. And I'll use the Stalin and Trotsky analogy again. You could say Stalin is wrong, but that doesn't mean Trotsky is right. So if DSM is Stalin, the anti-psychiatry people who think that all biology is wrong, diseases don't exist, and drugs are terrible, they're the Trotsky equivalents. They're wrong too. And they criticize DSM for the wrong reasons. Their criticism is that it's too biological or too medical. In fact, my criticism is that's not medical at all. It's not biological. It isn't like the rest of medicine because it's not based on scientific clinical research and biological research. And if it's valid, I'm not arguing that it needs to be biological. For instance, we can have valid psychological constructs that are not biological, like post-traumatic stress, for instance. It's just my only claim is that we need to base it on scientific data, whether it's psychological, biological, whatever, not just opinion, which is the postmodernist perspective. See that I'll just flesh this out for you. The DSM leaders in the 1970s were very influenced by the movement of the 1960s, which was the counterculture, the hippies, the 1968 revolts in Paris. You know, in Paris, you know where the students attacked in the 1968 revolt, one of the buildings that they attacked? The psychiatry department of the University of Paris. They attacked and they actually occupied the office of Jean Delay, the chairman of the Department of Psychiatry at the time. And he was never able to come back. He retired. He never was able to go back to his office. And that was because they saw psychiatry as their enemy. And the reason they saw psychiatry as their enemy was the same reason the current anti-psychiatry people criticize psychiatry, is that they're all in this postmodernist tradition that began with various thinkers, but became popular with Foucault in the 1950s in France and his attacks on psychiatry as a social construction. Psychiatry is not a real biological process. It's just society deciding to label people a certain kind of way so it can control them, not different in principle than just passing laws and having the police put people in jail. Psychiatry essentially are the policemen of the medical world. And he argued, of course, that was the case for other medical conditions, not just psychiatry, but psychiatry was a good example. And homosexuality was kind of the classic case where psychiatrists had labeled that. And then it turned out that, you know, obviously the society changed its view and then they unlabeled it in 1973. It's interesting that the leader of the movement to unlabel homosexuality as a mental illness in 1973 in the US was Robert Spitzer, who was the same guy who had a DSM-3. So they were really influenced by this notion that diagnoses are social constructions. They're just belief systems, labels of a certain group. They don't really reflect diseases or biology or illness in the same way as maybe some medical conditions. And that's why the DSM-3 leaders felt okay with diagnosing 270 things out of nothing, because they were social constructions. And that's my critique of them. I say that DSM-3, 4, and 5 is a social construction of the American psychiatric profession in terms of what it likes and what it wants. That is not the reality of biology, genetics, pharmacology, or nature. And therefore, it doesn't correlate to real disease processes in the real world. And the critics of DSM also say that social construction is a good thing. They just want to have a different social construction than DSM. They want to get rid of pathological terms and they want to talk about mental states in other ways. I disagree with all the social constructions of both groups, and I'm just trying to find out what the truth is.
Okay. And this may sound weird, but you are considered an expert. Is that right?
An expert in what?
In your field? I mean, in mood disorders or in
Yeah, I'm considered an expert in mood disorders, depression, bipolar illness. Some people would say maybe more broadly diagnosis, because I've published and done research on that a lot, and also psychopharmacology. I've written a textbook on that, and I published on that topic.
Yeah, and your book is half clinical observation. You've written a book. I mean, you know what? I've read I think 1,000 books. Like I have hyperthemia, so I can read a lot of books. I kind of do
You
that.
have the energy.
Yeah, I have the
Good.
energy. I have to sleep because I have bipolar, so it's a waste of time. But I have the energy of it. I don't remember most of the books. I just forget them. But I can remember when I saw your one. Yours, you have half of the book is just clinical observation and critiques of uh, statistics and epidemiology, etc. And I don't know. That was brilliant. Honestly, I know if you're going
Thank
to
you.
write another book, but that's brilliant. I mean, I don't get why your book is not really known. I mean, it's all right. It's nothing like Stephen Stahl or something. And I'm wondering, as a critic of about everyone or close to, how are you received in your field? Like, are you an outsider? Are you someone to be shut down? Do you lost friends? What happened to you?
Well, I mean, so the psychopharmacology textbook is called Clinical Psychopharmacology. It's published by Oxford Press. Came out in 2019, so it's 5 years. Um, and we're going to do a second edition. So, I actually wrote it specifically in a way to be an alternative to Stahl, or an opposition to Stahl's textbook, because it's a completely the opposite perspective. Stahl's textbook is biological and speculative and very aggressive in support of drugs. My textbook is clinical and research-based, not speculative. Clinical, not biological, research-based, not speculative, and very conservative in the use of drugs. So it's the alternative. And I'm hoping eventually with time it might pick up. So we'll see. You never know about things, about what succeeds and gets attention and why. A lot of it has to do with cultural and social trends. So, I can put the ideas out there, and then we'll just see if there's a cultural and social trend of enough interest to make it more and more known. Um, Sometimes you're before your time and it doesn't happen till later. Sometimes you're after your time, but we'll see. But in terms of your specific question about how I'm received, um, there's a couple things I could say about this. I don't know how I haven't thought it through, so I'm just going to share my thoughts as they come to my mind. Um, as I said, a lot of my critiques, especially around DSM, have only happened in the last 10, 15 years. And I'm in my late 50s now. That means I started them in my early 40s. And I started the profession in my mid to late 20s. So in the first decade or two of my career, when I was younger, I was not as critical. And I was able to get jobs and get grants and publish and move up the ladder and get some recognition. The time that I've started to be critical is more in the middle phase of my career, where I'm already a full professor. I'm not losing my job over anything that I say. And, I've already published a lot. I've already gotten a lot of grants. So in a way, I'm in a place in my career where it's hard for people to hurt me. There's not much they can do to me. So maybe it would have been different if I was like this from the very beginning, but I wasn't, to be honest. Some people would say I was always a little critical, or um, I was definitely looking for new ideas from the beginning, but I was not like just a radical anti-mainstream person. And I still don't think I am, but I was less critical back then. And my other observation is that I've had a lot of mentors over the years, older mentors, many of whom have passed away, some of whom were rather prominent, like Athanasios Koukopoulos, Frederick Goodwin, people that maybe not been mentors, but I was close to, like Haga Pakisco. And they had a lot of the same ideas that I do, and they had a lot of influence, some of them, but they didn't express them as much. And even when they got older, I noticed that they weren't pushing their ideas, even though it seemed to me like they were running out of time. They were getting older. And so to me, it seems like, partly as I get older, I feel a little more free to push things, partly because, I'm not 25 or 30 anymore. I don't have forever. If I'm going to see any change, I need to push it myself harder. And um, and I also think that there's less to lose as you're getting older. Like I said, you kind of get established, you have more credentials, and I think younger people are more at risk, where there's more potential problem for them if they are seen as too outside of the mainstream. One other thing I'll say about this, it is probable that I've not gotten certain jobs in my life because of some of my views, including views that are really quite minor compared to the things we've been talking about. For instance, in my career, I've always been critical of using antidepressants in bipolar depression. We did plenty of research from the very beginning showing they didn't work. People didn't like the idea, but I always pushed it. And I think some people didn't like that. They didn't like criticizing drugs at all, antidepressants at all, in any circumstance. So I think I probably was not hired for certain jobs. I remember interviewing at Massachusetts General Hospital, University of Pittsburgh for certain jobs. And I know I didn't get those jobs, partly because some people there didn't like my ideas around some of these issues. Um, but I would just get jobs other places. So maybe it harmed me in a certain kind of way in terms of not being able to work in certain places. But I was
Yeah.
always able to find a place where I could work, where I could continue to have and develop the ideas that I have.
And what happened to the people that put for the 14 diagnosis before the DSM-3 was written? Well, what happened to them?
It's interesting that the leaders of the research diagnostic criteria, the RDC, were located in a couple different universities, but a lot of them were in this one place, the Washington University of St. Louis. And they supported the DSM-3 process, working with Robert Spitzer, the guy I mentioned, who was at Columbia University in New York. And Spitzer brought them into the DSM-3 task force, and a lot of their definitions were included in the DSM-3 definitions, which we still use, like for so-called MDD, major depressive disorder, bipolar, et cetera, now. Um, but they were unhappy when they saw that the 14 diagnoses were, that they were adding 100, 200 more out of thin air. And so many of the leaders of the RDC group resigned from the DSM-3 task force. One of them actually committed suicide, not necessarily related just to that unhappiness, but the stress of the task force affected that person strongly. But a lot of them actually just resigned and stayed away from the DSM-3 process afterwards.
Okay. Did you know that Ellie Robbins had multiple sclerosis?
Did
And
he?
yeah, and it was, I think that's something that people have to know. I mean, he's among the people that put forth
Yeah,
the
the
14
RDC.
diagnoses, yes, and
Yeah,
he had to do psychoanalysis, like
yes,
every psychiatrist at the time, I think, and
yeah,
he was diagnosed as having hysteria because he had
yeah.
some weird movement disorders,
Oh, interesting.
and I think really that wasn't humanistic at all. And it kind of lit a fire in him, I think, to fight for something more medical, more scientific.
Yeah.
And
Yeah, I didn't know that about him, but I'm very sympathetic to him and his group at the Washington University of St. Louis. Like I said, I would say that the simplest thing we could do is to just return to the RDC attitude, maybe add a C before it, clinical RDC, just to emphasize that we're talking about clinical research, not just NIMH biology. And just return to that attitude and say, what do we really have for validated diagnoses where the genetics and the course of illness and the biology differentiates syndrome X from syndrome Y? And I think we would find back then they said 14, most of that's been disproven. I would say we have like 5 or 6. And then the rest of it, people are free to think however they want to. That's the approach I would take.
you've written another book on statistics.
Mhm.
Like I think I kind of sound like a fan. I think it doesn't really matter. It's fine. Um, can you expand a bit on the clinical trials of um, relapse prevention, please? Because I think yeah, it's
Yes,
priceless.
very, very important point. So can I give a little context first? And this relates to the larger discussion. we use drugs in two ways, for symptoms or for the diseases that cause the symptoms. If you use them for symptoms, it's like aspirin for a headache, Tylenol for a fever, ibuprofen for pain. And if you use it for diseases, it's like statins to lower your cholesterol so that you don't have a heart attack, or antihypertensive drugs so that take them for years so you don't have a stroke. Now, you notice in both of those cases, there are no symptoms. You're not treating any symptoms with antihypertensive or statins. What you're treating is a disease process so that the course of the illness changes. You don't develop the stroke, you don't develop the heart attack. And you either prevent it fully or you just have it less severely or much later. You could also use the same examples for disease-modifying therapies for multiple sclerosis, like you mentioned, which are anti-inflammatory drugs, which prevent the crises of MS, as opposed to steroids, which are symptomatic drugs, which you only take after you develop the crisis. So my claim is that in psychiatry, almost all of our drugs are symptomatic. There are like 50 variations of Tylenol and aspirin and ibuprofen that make your current depression, anxiety, or cognitive symptoms better, as opposed to disease modifying, which would be drugs that would prevent those symptoms from happening or make them go away and stay away in the long-term course of the illness. And that's what we have with lithium, for instance, being the best definition of a disease modifying drug that makes mood episodes go away completely, whether you're bipolar or unipolar, it doesn't matter. Lamotrigine may do that as well to some extent, maybe all the mood stabilizers. So when you get to the issue of identifying whether a drug is more than just symptomatic, more than just aspirin and Tylenol, then you're going from just the short-term current symptoms to something else longer term. Almost all of our studies, say for depression or for psychosis, for schizophrenia, are short-term studies, 2 months long, 3 months long. The patient's psychotic, you give them an antipsychotic, you show that their psychotic symptoms improve, you get an indication to go onto the market. Patient's depressed, you give them an antidepressant, 2 months, the symptoms improve, you get an indication to go on the market. What they don't show is that when you stay on the medication 6 months later, 1 year later, 2 years later, the symptoms stay away or they don't come back. For that, you have to do a different kind of study, and these are called maintenance studies. The thing about maintenance studies is what you're doing there is you're trying to prevent episodes from coming back. That means in the case of mood illness, someone can't be in an episode now. The episode's got to be gone. You take the medication and then you keep it from coming back. So the current mood state needs to be wellness. You can't be depressed. You can't be manic. You can't be psychotic. You have to be fine. And then you see how long you stay well. Well, the way that they do this is they take people who are sick, who are currently depressed, say, then they give them an antidepressant. Or they take people who are manic and they give them an antipsychotic until they get well. And once they're in the well state, they then see if they stay well. But at that point, they have to compare them to another group like placebo to see which group stays well. And normally those studies are about a year long. So one thing to point out is that we don't have studies that are randomized, which is compared to placebo, that shows you it's really a drug effect and not natural recovery. We don't have studies that are longer than a year in most cases. And the way they do these studies, though, is because they give it to the patient when they're sick. They usually use the drug that they're studying. So if I want to show that Seroquel, quetiapine, is effective in long-term treatment of bipolar illness, I take a bunch of people with depression or mania, I give them Seroquel until they're well, and then I randomize them to stay on it or to come off of it, and I follow them for a year. And when they come off, they go on placebo. But if they don't get well on the Seroquel, I don't put them in my study. So these maintenance studies always exclude people that don't respond to the drug that they're studying. So that in itself introduces the bias. So here's the metaphor I like to use. Suppose I want to compare chocolate cake and vanilla cake. And I find out, you like chocolate cake, but I want to study vanilla cake. I want to show that vanilla cake is good. So I find out you like chocolate, you don't like vanilla, you're not in my study. I only include the people that I know like vanilla cake. I've had them taste it already. And then after I've identified 100 people that only like vanilla cake, I randomize 50 to keep getting vanilla cake, and the other 50 get chocolate cake. And then I say, which one do you like more? And obviously the vanilla cake wins. That's because I've already pre-selected my sample to only like the vanilla. And that's the way these maintenance relapse prevention designs are. They pre-select the sample to already respond to the drug that's being studied, And obviously, it always does better than placebo. And the proof of that is, one more point on it, that when they take the patients off the drug to which they've just responded for the last few months, and they put them on placebo, they relapse quickly within a few months. And all of the benefit is that the drug is better than placebo 1 month later, 2 months later, 3 months later. But they follow them for a year. And when you get to 6 months or longer, you no longer see any benefit with a drug over placebo because it isn't a long-term benefit. They're not preventing a new episode 6 months or a year later. They're just showing that the current episode that they just had a few weeks ago, a few months ago, got worse when they stopped the drug that made it better a month or two later. So that's not true relapse prevention. It's just current acute symptom treatment effects again. So we're being fooled by the maintenance indications in psychiatry. We have the acute symptom indications, and then the maintenance indications is really just simply the same acute symptom indications wrapped up in a different picture. And it fools people to think that these drugs are actually effective long-term when they're not proven effective long-term. And that applies to antidepressants and so-called MDD and antipsychotics in bipolar illness and probably antipsychotics in schizophrenia too. I don't think they've been proven effective long-term. I think they've actually been disproven, and they're not effective long-term in the case of the mood illnesses, at least for sure.
And what happens if you do the same with something like lithium? You cherry pick people that improved on an acute phase.
It doesn't matter what drug you use. Whatever you cherry pick,
Same.
whatever you pick for, you'll see improvement. And that's another point. Like, I can't say 100% of the time because there might be an exception, but 99% of the time, using this design, you can prove that anything is effective over placebo. It doesn't matter what drug it is. It always works, almost always. In the case of lithium, though, we have studies that are not done this way. These designs have been used more since the 1990s, maybe the 1980s, 1990s. But in the 1950s, 60s, 70s, into the 80s, when the lithium maintenance studies were done, they were not done this way. The way they did it is they took people who got well, however they got well, on whatever drug they took, and then they randomized them to get lithium or placebo, separate from that. And that's a fair design, and that proves that lithium is effective for prevention of depressive and manic episodes in both bipolar and unipolar illness.
And would you say that lithium is on uneven grounds when we're studying the science? I mean, as far as today goes, seems like lithium is tried on inpatients, on patients that are not cherry picked, as opposed to the new drugs, and you get an inflation of effect size. I mean, I've looked at the effect size of quetiapine. I don't know if you've seen the first study of quetiapine, the Boulder one study, and they literally made everyone stop that drug. They stopped cold turkey, and then they were randomized to taking quetiapine again or taking placebo. And what do you know? You're better off if you're picking quetiapine, and there's an effect size of 0.1 or something like that. That's insane.
Yeah, of one or something. Yeah. No, it's just a withdrawal effect. By the way, you can show the reverse. So there are 7 studies in which patients were randomized to placebo instead of an antidepressant. And then they got better on the placebo for their acute depression. And then 8 weeks later, they were randomized to stay on the placebo or to get an antidepressant. So these are people that responded to placebo. And then they got randomized to staying on placebo for a year or getting antidepressant for a year. And the placebo was better than the antidepressant in the long-term relapse prevention. So it proves, that you can prove anything as long as you select for whatever it is you select for.
I had someone who, I said I was going to ask you questions, and the question that came most frequently for me to ask you was, what do you do when you see someone with bipolar disorder that has an antidepressant? What do you do? What do you do?
Yeah. I mean, that's been my bread and butter of my practice for 30 years. What I do with those, they keep me in business. They're most of the patients that I see. I just take them off the antidepressant, no matter what. If they're well, if they're sick, if they're manic, if they're depressed, if they're mixed, they all go off. And there's 2 reasons for it. One is they're proven ineffective. Antidepressants have been proven effective. It's the same effect as placebo. for the acute bipolar depressive episode. That's been shown over and over again. We had a meta-analysis a couple of years ago we published that showed that. So overall, when you took all the studies, and there's about a dozen studies, there's not hundreds, but there's about a dozen studies, and they show that. So if you have a drug that's the same as placebo, it's proven ineffective. Why would you give it to somebody? There's no rationale on the efficacy ground. And then on the mania side, they obviously can cause mania in some people, but more importantly, if they're taken long term, they cause rapid cycling, which is more and more mood episodes over time in about 25% of people, and that's more than placebo. And we've shown that it's been shown 3 or 4 times over in randomized trials. So they also can cause mixed states, of course. So if you have someone who's on antidepressant, they have bipolar illness. If they're depressed, well, it doesn't work for them anyway, so you can stop it. If they're manic or mixed, well, it makes that worse, so you can stop it. If they're rapid cycling, it definitely makes that worse, so you should stop it. And if they're well, it's not working anyway. It's placebo, so you should stop it. There's zero rationale to ever have a patient on antidepressant with bipolar illness.
And some are well, and you don't get to see them anyway, and so it's not really an issue. I mean, I have patients.
Yeah.
I ask about the family, and it's obviously some kind of bipolar, and they're on an antidepressant for like 40 years, and it's no issue. Do you stop them preventively, even if they're fine?
I would.
Okay.
Because it's
Yeah,
it's just a matter of time. I mean, I've seen a person have their first severe manic episode when they're 85 years old, land up in the hospital fully psychotic. So as you age, as you get older, if you have manic depressive illness of any variety, which includes the mild hyperthymia, cyclothymia, there's an increasing probability eventually of having a depressive episode or a manic episode. And when that happens, it can either be very harmful, with financial consequences, or obviously with depression, with suicide. So, antidepressants and efficacy is zero, same as placebo, and the risks are more than zero. So I don't think it's ethical to stay on them. Let me say one more thing about that efficacy issue, though. And I can give you a case example if you want at some point of a friend of mine who actually committed suicide on his second depressive episode when he was 69 years old. But let me say something about the placebo issue. When I say it's the same as placebo and it's ineffective, I don't mean that the patients don't get better. They actually get better. Whether they're on antidepressant or placebo, they get better. In both groups, it's equal. So the mistake that doctors are making is they're giving the drugs to the patients, and the patients get better, and the doctors draw the logical conclusion that the drug made them better. But actually, the randomized placebo-controlled trials show they prove that the drug did not make them better. They got better for other reasons, most commonly the natural course of the illness, that they recover anyway. So when you say they're on the antidepressant and they've been well for a long time, they got well anyway. It wasn't because of the antidepressant. And they're staying well anyway, just because they're in a natural remission. It's not because of the antidepressant. So there's no reason to be on it.
Okay. Can you tell us about your friend?
Yeah, so my friend, so this is an example about why it always matters to not underestimate that you could have a future depression or mood episode. So I had a friend who was a historian, a very well-known historian, professor, and he had a depressive episode in his mid-30s. He was suicidal. It lasted about a month. He was psychiatrically hospitalized and treated with tricyclic antidepressants back in the 1970s. He got better, fully better, stayed on it for a few months, and then stopped it. It was his first depression, and he was fine after that. He went into a natural remission and didn't have another depressive episode for 30 years. And then at age 69, after he'd retired a few years, he was happy in a stable relationship, good relationship with his kids, financially totally stable, academically happy. He was retired, but still very active. He had no stress in his life at all. But the depression just happened out of the blue. Now, in retrospect, I was his friend. I wasn't his doctor. But in retrospect, I had known him for about 10, 15 years. If I reviewed it now, and at the time I wasn't thinking this way, I would say that he had hyperthymic temperament. He was always a high energy guy, very talkative, very creative, but also a little edgy. He would, in his debates with historians, he would take a side and he would argue with other people, and some people didn't like him. but he was very creative and a very, very charismatic guy. He also had a very high sexual drive, very high libido, especially for a guy in his 60s. He was really going. So in retrospect, I think he had some of these manic symptoms, not episodes, which were part of his hyperthymic temperament. And then that may be why he got depressed. People with mood temperaments like cyclothymia, hyperthymia are more likely to have depressive episodes probably than the general population. And so he was probably hyperthymic when he was a teenager, had a depression in his 30s, remained hyperthymic in his middle age, and had another depression in his late 60s. He got depressed, he got Zoloft, and he had some traditional depression symptoms: sad mood, low energy, anhedonia, a lot of despair and suicidal thinking. And his libido stayed high. He did not have a decrease in his libido. So I thought that was interesting. He got some Zoloft,
On
and
Zoloft, yeah.
before the Zoloft,
Yeah.
that's how it was. He got the Zoloft, and for 4 hours, his energy went through the roof. He called me and told me, I suddenly felt really energetic for 4 hours. I wanted to just run all over the place. I felt great. My mood was really good, and my sexual drive suddenly went up 4 hours, and then it went back down. Suddenly, he was despairing, despondent again. And I told him, to me, those are manic symptoms for 4 hours. Now, people say ignore it if it's 3 days, so they're going to ignore it if it's 4 hours. You go to any doctor, any psychiatrist, they're not going to diagnose this. But if it was me, I would take you off the Zoloft and I'd put you on lithium for two reasons. You not only have a depression, but you also have suicide. He was having suicidal thinking. And he said, I agree with you. And he was a very educated guy. We talked about mood illnesses a lot. But I can't convince my primary care doctor who was treating him to do that. So um, we talked about trying to get him a specialist. Eventually, to make a long story short, he ended up on multiple antidepressants, multiple antipsychotics. He saw multiple psychiatrists, went to the emergency room multiple times with suicidality. Nobody ever put him on lithium. And eventually he jumped off the 20th floor of his building. He was in a mixed state in retrospect, and the antidepressants made the mixed state worse, in my opinion. So that's an example where you apply DSM definitions and they don't work out. The hospital that he was treated in actually did a ethical review, and they concluded that all the doctors had done nothing wrong because they had gone by the DSM definitions, they had gone by the mainstream treatment guidelines, they had not done anything that's outside of the standard of care. But it still makes the point that the standard of care and our mainstream approach is actually not effective for people who have these kinds of conditions like mixed states and mood temperaments.
And did any of the doctors treating him call you at any time?
No, no, but I was in touch with him and indirectly through him with some of the doctors. And there was one doctor that I was going to get him to see, who was a bipolar specialist, who told me, yeah, he was willing to give him lithium. He was the only guy. But by the time we were going to get him to see him, it was a few weeks after he died.
And how old were you? Well, when that happened?
How old was I when it happened?
Sorry.
This was about 10 years ago, so I was in my late 40s.
Do you think that that's something that kind of lit a fire in you to make things change?
Yeah,
Yeah, I'm stating the
it
obvious,
probably
I
did.
guess.
Yeah, I mean, I actually went to that hospital and gave grand rounds a few years later, and I talked about the case with people who were there who treated him to try to teach them more about it. But it was around the time that I myself was getting more familiar with these ideas. So I will say, besides the DSM, something else that's changed in my thinking in the last 10 or 15 years is I pay much more attention to mood temperaments, like we've discussed. If you look at my writings from some of the books I wrote on mood disorders, like in 2007, I don't talk about it hardly at all back then. I didn't think about it much. And it was under the influence of Koukopoulos in Italy, mainly, that I started meeting him around then, and I started learning about these ideas. And then once I started applying it in my practice, I realized it made a big difference. And his case is one that stood out in retrospect, that if I had been more aware of the hyperthymia concept at the time and I applied it more strongly, I think I would have pushed more. I was, you know, what I did was I gave him my advice, but I didn't push it. I was a little complacent. I didn't think it would go badly as quickly as it did. And now I know that with patients with hyperthyroidism, especially because they're always high, when they get depressed, it's a really deep fall. And usually it's a mixed state too. So they're very high suicidal risks. And the use of lithium for me has expanded extensively. Anybody with any suicidality, I give them lithium, at least in a low dose. I don't delay and I don't hold back. Whereas before, 15, 20 years ago, 25 years ago, I didn't used to give it to people as much. And I had at least 4 or 5 suicides from back then that I, in retrospect, can think back to. Some of which might have been preventable with a more aggressive approach to using lithium.
What about ketamine? I have no idea. I haven't seen your thoughts on this one because in France, it's reached epidemic proportions. I think everybody gets
Yeah,
ketamine, and now it's esketamine, right? So it's so much money. I mean, it is a
yeah,
lot of money, and it's being used about in every university hospital because it reduces suicidality, etc. What do you think? I'm pretty biased. I think biased.
yeah,
Is this?
yeah. I haven't written anything about it much, but I did have a podcast episode where I just talked about it because it's not something I've gotten to. There's a lot that needs to be described. Um, I call it super Tylenol. Ketamine is super Tylenol. So it has all the same benefits of a really good Tylenol, but also the uselessness of it. It's a sign of the intellectual weakness of our profession that we are so excited about ketamine and psychedelics because they get people's symptoms better even more quickly. And it's just this pure focus on just a symptom approach to treatment. Infectious disease specialists who only care about fever and totally ignore the diseases that cause fever. That's our approach to mental illness. And I think it's intellectually bankrupt. And it's a shame. It's a tragedy, in my view. So I think ketamine's a waste of time. I don't give it to people. I've seen people who've gotten it, my patients who've gotten addicted to it. I've seen people get manic on it over and over again and psychotic. I think it's dangerous. I, I have other colleagues who tell me opposite, colleagues who I trust, who tell me that if you carefully select people, you rule out the bipolar patients, and you give it short term, especially, it can help some people, almost like ECT. And if that's used that way, I would be open to that idea. But this widespread use, the way it's done now, and especially long term, as if you're solving any long term problem, which you're not, you're just repeatedly trying to just treat symptoms. To me, that's a waste of time and it's not revolutionary. It's not transformative. It's nothing special. It's a sign that our profession doesn't have any good ideas anymore.
Yeah, because it's nothing new, right? It's ketamine and
Yeah, it's
MTR
also not new. I mean,
rebranded.
some of the psychedelic interest is going back to the 50s and 60s. You know, it's an when because DSM is false and our diagnoses are wrong, our treatments don't work. So we've run out of ideas. And now we just go back to what people thought 50 years ago. No other medical specialty does that. It's unscientific. There's no progress. It's really sad.
Yeah, okay, I agree. Uh, like
But
if you
there is
have
a solution. There is a solution,
which is
which is clinical research diagnostic criteria, using scientific criteria for diagnoses, and then using drugs to treat diseases, not symptoms. Essentially, it's just doing what the rest of medicine does. We should be doing that. And given how mental illnesses and psychiatric diseases are so harmful, this is not it shouldn't really be an optional thing. We really should be upset that we're not helping our patients more than we are.
and
They're upset for sure.
what keeps you going then? Because I may sound pessimistic, but from where I'm standing, it's not going in that direction at all. So
Yeah,
yeah,
well,
what keeps you going?
it's true. I don't know. I mean, I sometimes get asked that question and I don't honestly know the right answer. I don't I it's not I don't think that I'm what keeps me going is some kind of idealistic urge or energy or commitment, not something virtuous like that. It's not really that. At one level, I don't know. What else would I do? I'm a psychiatrist. These are my ideas. I practice. Other than retiring, I'm not sure what else I could do. So I just keep expressing my views, whether or not it's popular, whether or not it gets accepted. That's a secondary consideration because I don't have any option but to express my views. I mean, they are what they are. So I don't know. That's not. I don't think it's anything heroic. What keeps me going is just I happen to be living, and this is what I think. So I just say it. And obviously, I would like the world to accept the ideas more, and I would like things to change. The one thing that does keep me going, I guess, is I do see patients. You know, I treat patients just like everyone, and in a single case by case by case, I help my patients, and that gives me the confidence that this could actually help at a larger level. And even though it's a small group of people who read my books and who may see my website and practice, but I get positive feedback from some clinicians there. And, you know, I'm hoping that that's true and that that becomes a little bit of a larger ripple of benefit. And I guess I have a little faith, you know, that that little faith that you don't know what the future is going to be like, but as long as you put out some truthful ideas and they will actually prove themselves in the real world, and that the in the future the world eventually will will recognize those truthful ideas. So I guess I have some faith that over time that will grow in a positive direction because it's true. If it wasn't true, then I would be pessimistic. But if it's true, which I don't know, obviously, I think it is, then I'm more optimistic about it.
You know, this is why I think you can make a change in France because there is no DSM in France. I mean, many psychiatrists don't even really know what's inside the DSM. I mean, the criticisms, I mean,
That's good.
they've probably heard criticism of the DSM more than what's inside, really. So
That's good.
when a new version comes out, it's everyone is like, this book is atrocious. There is no humanistic thinking behind. It's not helping anyone.
Mhm.
So there is
Yeah.
a lot of things to criticize about the DSM, but I don't think these are the one. We've talked about that. But I think, you know, France is so unstable as far as
Yeah.
psychiatry goes, and maybe you can reach out some people. Do you have experienced stigma as a psychiatrist?
Stigma.
Yeah, I don't know if you know what I mean. I feel like if I was practicing cardiology when I was saying something,
Yeah.
you know, it would feel like you know it's going to be this way. So there's no way around it. So there's not a pharmacist that says, no, I would rather have something else. There's no criticism. There's not people saying like you should stop every drug so because you have too much and maybe you'll be better off. And I get criticized by pharmacists, by
Hmm.
colleagues. I mean, I've called colleagues and I've told them, look, there is data on this and this and this. We should try this one. And most of them don't really bother to even answer my questions. You know, to just say, I'm not going to change my mind. I don't care. And I was wondering if, because I'm nobody, you know, I'm a psychiatrist. I have no influence. Nobody knows my name. I mean, I'm just nobody. I was wondering if, as a professor, you had the same issues sometimes because
Well,
of
you
the
know,
profession.
yeah, I think that's true, and psychiatrists have always complained about it, including in academics. Mm, it's interesting to me. I was always sympathetic to the view that I think many psychiatrists have that other physicians discriminate against psychiatry wrongly because they just don't understand or they have biases. But I've come to the conclusion gradually that I'm actually sympathetic to the stigma, the criticism that other physicians make of psychiatry. I think they're unconsciously correct. I don't think they realize why they're correct, but they have an instinct that there's something wrong with psychiatry. And we push back and we say, no, it's your problem. But actually, I think they're right. I think it's our problem for all the reasons we discussed before, that we are not medical. We are not scientifically medical. And it they don't understand this whole symptom disease distinction that I've made. They don't know the inside outs of DSM, but they understand that what we're doing isn't right. And so in a way I'm not defensive about it anymore. And I think that we need to be more self-critical as a profession. I will say my father's a neurologist. and I have a lot of neurologist friends. And when I talk with them, I realize that they instinctively think the same way I do. But psychiatrists aren't trained well enough in the medical approach, it doesn't stick with them, and so they don't think this way. It's almost like we have to retrain psychiatrists to become physicians again after their specialty training when they go off the medical path with DSM and all the
Yeah.
symptom-oriented thinking.
My grandfather hypothermia. He was just on non-stop. Like he slept 3 hours a day up until 103 years old. He just never
Good
stopped.
for him. Wow.
And I came to him and I said, "Hey, Grandpa, I'm going to start psychiatry." And he said, "What a shame! What a shame! You should have
Yeah.
gone to neurology." And at first I had a white coat and I used it, and I've stopped wearing that coat because for now I don't think we're doing medicine. I think
Yeah.
most of us are not doing anything close to
Well,
medicine.
Michael, I think you're doing a lot of good because if I'm right, and you're right, and some of these ideas are right, there's a lot of wrong thinking that's not helping people, and by steering them in a different direction, you're doing a lot of good. So you're an exception in the case of um, going into psychiatry and really actually helping people. But I do think that on the other hand, your grandfather might have been right in a general sense, in that if people go into psychiatry and they just practice mainstream psychiatry the way it is, I don't think it's a huge help to people. Anyone could do it. Other people will do it. And other disciplines in medicine help people more. Thankfully, all of us are going to get exposed to illnesses of various kinds. I've recently had some illnesses myself, and I'm very thankful that the doctors that I go see are not psychiatrists, practice medicine very scientifically and in a disease-based approach. And I wish that we could do that for people too.
I'm going to ask you the weird questions again. What do you answer to people that say, "Look, I've been practicing for 20 years and I've seen this work and I don't really need anything else to change my view," especially when you're dealing, I think the knowledge comes from the university, and when you are treating patients, you only see for a brief period of time, see them 3, 4 times, 6 times, and then it's off to the general practitioner, usually, because there's no psychiatrist anymore. And what do you answer to these people? Because some people are going to watch the video and say, "Yeah, but I've been treating patients with antidepressants for decades, and there is
Right.
nothing that."
Well, when I was younger, my answer to this question would cause me to have enemies, and the answer was, doesn't matter what you think and doesn't matter how long you think it. Just because you think it and see it doesn't mean it's true. In the history of medicine, people thought that bleeding and purging and laxatives were true for 2,000 years. So they practiced medicine by looking at black bile, yellow bile, blood, and phlegm. And then you got leeches and bleeding for 2,000 years, not 20 years, 2,000. And they were wrong. So it doesn't matter how long you think or what you think. So that's the real answer, but people get mad. So now that I'm a little older, I give a more pleasant answer, which is this is an old saying in medical school in the US that half of what you learn is true and half is false. You just don't know which half. And that's because clinical experience is some partially true and partially false. And the only way you can know what part is true and what part is false is by going outside of clinical experience to randomized clinical trials. The whole concept of science, evidence-based medicine or science. That's why I wrote the book on statistics, was to explain this issue to people. The average clinician, when he says something like that, doesn't understand two words: confounding bias. Confounding bias means that you see things in the world and you think that A is causing B, but actually C is causing A, and you don't know about C. And D is happening in E and F. So, for instance, if you look at real world practice, people who drink coffee have high cancer rates. So if you were a clinician, you might say, "Hey, I have 20 years of experience that coffee drinkers get cancer." I'm not going to change my view. I have 20 years of experience on that. But actually, the coffee drinkers are more likely to be cigarette smokers, and that's why they get the cancer. And then if you did a randomized trial and you looked at the two groups, you would have equal numbers of cigarette smokers in both groups. So that confounding effect doesn't affect the results. So by randomizing, you can really tell if a drug has an effect. Whereas in real world clinical practice, there's all these other confounding factors that influence the results, and the clinician can't know that. In other words, you can't believe your eyes. You can't believe what you see. That doesn't mean that everything you see is false, but it does mean that everything you see is not true. So half of what you learn is true, half is false. Science tells you which half is which. And the problem with the average clinician and doctor is they're not scientific. They might as well have been practicing in 1500, 1000, 500 AD, bleeding and purging and laxatives for black bile and yellow bile, because they're just going by a belief system. And that's not science. That's why medicine was so ineffective for 2000 years.
And how do you know what to pick when you're reading science? Because as you just said, there is a lot of garbage in this.
Exactly.
How do you?
Well, I mean, you have to have enough scientific education to be able to differentiate some of that. You don't have to be a full-blown researcher. You don't have to get a PhD, or a statistics degree, although all that is helpful. But you should learn enough. And unfortunately, in medical schools, we don't actually teach statistics much. That's why I think it's important. We don't learn scientific methods. And that people don't do enough research. It would be nice if people did more research, because then they would learn how the research process works, which helps you interpret studies. But basically, you have to learn some of these methods. It's not that complicated. There are some basic rules on how to interpret clinical trials. I tried to lay it all out in a little statistics book, for instance. It's called Statistics for Clinicians, because I wanted to explain exactly what you're asking for at a level a clinician can understand. And if you do that, yeah, you can read the literature and you can interpret, meaningful findings from less meaningful findings. But it is not straightforward, because a lot of things get published in ways that can be misleading for various reasons. It's not always the pharmaceutical industry trying to make money. That's some of it. But a lot of times it's just that people have opinions and they publish their results to support an opinion, even though the data doesn't support it that much. So you do, it's not easy, but it can be done, at least to a certain extent.
And how do you keep up with the new things, the latest discovery, etc., etc.? Do you read every journals? How do you?
No, no, no. Well, I don't know that I keep up with the latest discovery and the new
I
things.
think there
And
is
maybe
such.
if I was not a psychiatrist, I would try to do that more, because in other disciplines in medicine, they have new discoveries that are actually useful and more so. For us, a lot of the stuff that's so exciting is just a waste of time, like new ketamine studies, new psychedelic studies. I don't give it, and I don't care at all about those things. So I don't try to keep up with them. But you hear about it anyway. Often it gets it in the news, or colleagues tell you about it, and then you can look up the paper if you're interested. But what I used to tell people is I would suggest reading two kinds of journals. One is a general journal, like just to keep up with the general attitudes of your profession where you are. In the US, it's the American Journal of Psychiatry, the main APA journal. In Canada, it's Canadian Journal of Psychiatry. I don't know what it is in France, something like
There
that.
is there's nothing. There's
There's
nothing.
nothing like that.
No, there's nothing worth
I mean,
reading.
it could be
Nobody.
Lancet Psychiatry,
Yeah.
for UK, something like that. A British Journal of Psychiatry. So one general journal, and then pick one of an interest. Like if you're interested in bipolar, read bipolar disorders. Or if you're interested in PTSD, read a PTSD journal. That way you keep up with what the specialists in that field of interest of yours are writing. And that's one way of kind of being a little more knowledgeable about a certain topic. So that's what I recommend, one general journal and one specialty journal. And that doesn't mean like reading every article and all that. It just means like maybe reading the titles, reading some of the abstracts, maybe picking one article or two that interests you every month. It's not that hard to do.
And what do you think about the CME credits? I don't know, like in France, I think we're the only country that spends so much on health and mental health, but there is no checking on whether or not physicians keep up to date. I think you have continuous medical education. That is something to be, I don't know if it's enforced or not, but in France, it's written in the law, but nobody's going to check if you've done it or not. So basically, it's not done. I think we are one of the only country in the world that spends so much without checking. How is it in the US?
In the US, it's checked sometimes. It depends on, it varies from state to state. And when you get your license in a state, you have to show them some evidence that you did continuing medical education credits in the last couple of years before then. But if you stay somewhere, sometimes they don't check for years. So sometimes it's checked, sometimes it's not. People do tend to do it. It's a very common practice because people don't want to get in trouble in case they get checked and they don't have it, and they might lose their license, which means they can't work. It's a good thing. Sometimes, of course, maybe some of the CME credits, I might not agree with what's being taught, and I might not think it's helpful to people. But in general, the idea is a good thing for the reason I gave you earlier. Half of what you learn in medical school is true and half is false. Well, the half that's false, you need to learn over time more about that half. And you get that as you get older with continuing education. So yeah, it would be good to have something like that in France. It's the only way that it's an important way to try to make sure that people realize that what you learn whenever you were educated is not going to be good enough for the future.
There is shortage in psychiatry, in psychiatrists in France, and so there is going to be a advanced nurse practitioner that are
We have that too.
popping up. What are your thoughts on that? Are you going to insult or offend someone, whatever you say, anyway? So you can
I'm sure I will.
go for it.
I totally support it. I think it's a great thing. And that's mainly because psychiatrists are so ineffective the way they practice. So it's hard to defend our profession for all the reasons we gave earlier. So how can we be critical of nurses, psychiatric nurses, or psychologists or others who want to try to help people? Maybe they'll do a better job.
Okay. Well, yeah, no, I think you're right. I think if the only thing you do, I think it's payback. If you see someone that's depressed, you prescribe an antidepressant, and who has anxiety, you prescribe an anxiolytic, and who can
Yes.
sleep, then anyone can do it in
Anyone
1 year.
can do that.
Anyone
You don't
can
need
do
an
that.
MD to do that.
You don't need MD.
And that's a good point. And that's a good point that the reason you go to medical school is so you can identify diseases and treat diseases. If you just treat symptoms, you don't need a medical degree and you don't need to be a doctor. Depends, nurses do get decent medical training. I mean, they're better than psychologists, for instance, on this issue. I've interacted with a lot of nurse practitioners and I supervise some. I consult to many. One of the benefits I see with psychiatric nurse practitioners is that there's two groups. One is realizes that because they're not doctors and because they're not psychiatrists, they realize that they don't know what they don't know, and they're open-minded and flexible.
Okay.
And with them, I can work them really well.
Yeah.
The second group don't realize that they don't know what they don't know, and they're scared and nervous because they do realize they don't know enough, and they're not willing to go outside of the mainstream and the standard of care.
Yeah.
And those people, I think, are much less effective. So I think it really comes down not so much to what your credential is. It comes down to how open-minded and flexible you are.
Okay. Yeah, I agree too much for us to discuss it. I think anyway, what made me a good psychiatrist, I think, is because I realized how bad my training was, and I tried to learn somewhere else.
Right.
So I think
Exactly.
nurse practitioners have the same training. It's going to be bad. It's not just because you're going to the faculty for
Yeah.
2 years. It's still bad.
Yeah.
And I think
No, I mean, I think you have a point. There's the occasional psychiatric nurse practitioner program where the training might be better than other ones, but still it's limited. It's nowhere near as advanced as a psychiatry residency, and even an average psychiatry residency would be. So I agree. I think if you take a psychiatrist, a good psychiatrist with a good training program who educates himself more in addition after his practice, that's the best practitioner. I totally agree with that. But I think in the real world, we fall very short of that ideal.
Yeah. Okay. What do you, I'm going to stop soon if it's fine with you. Do you prescribe out of the FDA approval? Because if you do that in France, you're insane. It's like I just like 2 hours ago, a pharmacist I prescribed pramipexole, and a pharmacist just refused to deliver the drug because it wasn't FDA approved, and the
Mm-hmm.
patient committed a suicide attempt,
Mm-hmm.
a serious one. So the husband left her. So I'm there trying to fix things. I mean, the pramipexole may have not worked, but the pharmacist just did not want to deliver it because it
Mm-hmm.
wasn't approved. What's your opinion on FDA approval then, etc., etc.?
I think FDA approval is a minimal standard for scientific quality. It's not the maximal standard for scientific quality. Unfortunately, people treat it like the maximum when it's the minimum. So what the FDA approval just says is we have a little bit of evidence that you could use this drug for X. And usually it just means you have two randomized trials that are positive. Sometimes you have 10 trials that are negative. So, but as long as you have two that are positive, they'll approve it. And then it's dependent on a pharmaceutical company spending the money to get the FDA approval. Well, they're only going to do that for a patented drug. They're not going to do it for a generic drug because they won't make any money off of it. And they're only going to do it for a patented drug in an indication that their economics department has determined will make them a good profit. They won't do it for other indications. So if you only go by the FDA approval, you're basically letting the pharmaceutical industry decide how you practice medicine. And that's not correct, and it's not even required. In the US, the FDA makes it very clear that an FDA approval is just a reason for a drug to come onto the marketplace. It's proven effective for at least one thing. Now, it could be effective for 10 other things that haven't been studied yet, but it's on the market. Once it's on the market for one thing, doctors can use it for the 10 other things if they want, off label, as long as they have some rationale. There might be some studies that are done by non-pharmaceutical companies, like by academics, who are looking at the indications the pharmaceutical company ignores because it won't make enough money. Or maybe it was on the market 20 years ago, now it's generic. And so since then, there's been research on something else. So I think it's good. You have to use medications off the FDA label if you're going to practice scientific, clinically effective medicine. Otherwise, you might as well give up the MD degree as well, like we talked about. Forget about the nurses. Let's just let the pharmaceutical executives practice.
Okay. Do you have any conflicts of interest?
Well,
I'm
yes, in a
worried.
way. I worked for until 2021 for 4 years. I worked at Novartis, which is a pharmaceutical company, and I was involved in their early drug discovery research in psychiatry. So that's why I know a lot of what I'm telling you right now, because I know how the process works when pharmaceutical companies develop drugs. And then after that, I was in 2022, I did an advisory board for Otsuka for long-term injectable antipsychotic 2022. And that was the last interactions I've had with any pharmaceutical companies.
Okay. Okay. Do you have any final thoughts or something you'd like to share to the audience?
What I'm my maybe if I try to give a summary is I think that contemporary psychiatry is relatively ineffective, even harmful at times, because it's using a diagnostic system that's mostly false, DSM, and it takes a symptom-oriented approach to the drugs instead of a disease-oriented approach. And the solution is built into that critique. We need to have a diagnostic system that's valid, which we can do based on scientific research. That will then identify the diseases, and then the drugs can be used more for the diseases. I think that the problem and the solution is clear, but actually implementing it is difficult, just like many things in our societies, whether in politics or other settings. Sometimes the problem and solution is clear, but society, for various reasons, because of all the interest groups, differing attitudes, people aren't willing and able to solve the problem. So I'm hopeful that I come across not as just critical and negative, but also as positive and showing a solution that even though it's hard to do, can be done. And each one of us in our own clinical practices can actually have practice these solutions in our own little worlds and make differences that way as well.
And what about the ICD 11th?
Oh yeah, we really didn't mention ICD, but everything that I said
Yeah,
about
I'm
DSM
going to
applies
be
to
asked.
ICD. Yeah,
Yeah,
sure. Sorry about that.
thank you.
Everything that we say about DSM applies to ICD, and everything we say about FDA applies to the European Medicines Agency. There's no differences on all those issues. They have the basic same standards. Unfortunately, the European leaders of ICD back in 1980, they went along with the DSM-3 changes. And not only that, because they agreed with it, they got convinced, they changed the ICD so that it correlates with DSM. So basically, DSM-4, DSM-5, every time APA makes changes, American Psychiatric Association, the ICD makes the same changes. So the Europeans are basically just copying the Americans. They have no independence. And ICD is really just a copy of DSM. So all the same critiques apply.
Okay. And my last question is out of curiosity, why did you accept such an interview with me? I'm curious.
Why not?
Yeah, no, okay, okay.
Yeah,
I
why
don't
not?
know.
I mean, well, I mean, I do interviews with anybody, almost most people,
Okay.
because partly I want to get the ideas out. I'm appreciative that other people are interested in my ideas to interview me. In your case, I'm especially appreciative because we interacted through my Substack newsletter and blog posts, and you had read what I had written and you had written to me about it. So I knew that you had made the effort to think about and maybe practice some of the ideas that I've been writing about. So I was obviously pleased to hear that and even more willing to have an interview with you and to collaborate with you to try to help get these ideas out even more. Because I'm only one person. I can only do what I can do. I need the help of people like you and others. To the extent that any of this is right, I need the help to try to get the ideas out there, to talk about it, to help me clarify more and change things to make them better. So I appreciate the opportunity.
Well, thank you. You've helped me. I think you've helped me a lot more than the psychiatrist I've seen, you know, and because of me feeling good, I've helped patients. I've read your things. I have not read things like this anywhere else. I've read a lot of stuff. Honestly, I really read a lot of. So I'm glad I have a chance to help you get this out a bit. I think it's the least I can do. So yeah, it's an
Thank you.
opportunity. I thank you so much for allowing me
Thank you,
to
Michael.
thank you, uh, and hopefully we'll stay in touch.
Okay, thanks.
Okay.